Very happy to be here today. I'm proud to be part of this initiative, and especially the task force group investigating the combination of anti-Her2 drugs with radiotherapy. I've been contracted as a lecturer for AstraZeneca, but have no other conflicts of interest. And my talk will be about the Her2-directed antibodies, trastuzumab and pertuzumab, and the TKIs, and then predominantly lapatinib, because when it comes to the newer TKIs, neratinib, tucatinib, and puritinib, we still don't have enough data. So this is an area of interest where we will need to do more research. And we look both at the extracranial adjuvant breast cancer radiotherapy and intracranial treatment. And I will start with just ruining all the excitement, giving away our conclusion immediately. And this is that we have found the concomitant administration of trastuzumab, pertuzumab, and lapatinib with radiotherapy to be safe, both extracranially and intracranially. But how did we come to this conclusion? Well, we start by looking at the adjuvant breast cancer radiotherapy. And here, of course, we have the most data for trastuzumab, and we have quite a few retrospective studies. I would say that most, if not all of them, have looked at cardiac toxicity, because of course this is something that you're very worried about when you combine a cardiac toxic drug with radiotherapy that could also cause cardiac toxicity. Varying a little bit in number and in follow-up time, from about half a year to up to around 5 years. Well, some of them have also looked at dermatitis and esophagitis. And collectively, the conclusion from these studies have been that the combination of trastuzumab and adjuvant breast cancer radiotherapy is feasible, safe acutely, well tolerated, and similar to patients with trastuzumab alone. So the conclusion here from retrospective studies is that the combination is safe and well tolerated in patients with normal baseline cardiac function, although, of course, we do need longer follow-up. Looking at the prospective studies and randomized trial, these two publications have been quite well cited. In the publication by Jacob et al., they followed 300 patients for a median follow-up of about 50 months, of which internal mammary node radiation was given to about 3/4 of the patients. An LVEF decline was seen in 8.4%. However, they did not find the treated side, left or right, or the inclusion of internal mammary nodes to affect cardiac function. In the publication by Hallard et al., they investigated over 2,000 patients receiving either only adjuvant chemotherapy or in combination with trastuzumab in different sequential. Of these patients, about 1,500 received concomitant adjuvant radiotherapy. The incidence of grade 3 radiotherapy-related adverse events was low when it came to acute skin reaction and pneumonitis, and they did not find any signs of an increase in cardiac events with trastuzumab and radiotherapy, regardless of treated side, with a median follow-up of 3.7 years. So again, in these studies, no significant increase in cardiac events. There have been two publications lately from the ATTEMPT trial, one looking at local toxicity in combination with radiotherapy, and the other at cardiac outcome. And as you may remember from the previous talk, in this study, stage 1 HER2-positive breast cancer patients were randomized 3:1 to TDM1 versus paclitaxel and trastuzumab. And radiotherapy was given concomitantly with the Her2-directed treatment. Looking at acute skin toxicity, this was investigated in about 300 patients receiving radiotherapy, and it was generally mild. There were only 2 patients in the study with grade 3 toxicity and no grade 4. As expected, a higher risk with conventional fractionation and with boost. Pneumonitis, seen in about 1% of patients in each study arm, grade 2 to 3 pneumonitis. And there were 2 patients with rib fractures, 1 in each treatment arm. So the conclusion here, when it comes to local toxicity, was that the present study demonstrates that breast radiotherapy can safely be given concurrently with either TDM or trastuzumab, both with conventional and hyperfractionated techniques, and with a lumpectomy site boost. In the publication on cardiac outcome, they found a grade 3 to 4 left ventricular systolic dysfunction in 0.8% of patients in the TDM1 arm and 1.8% in the trastuzumab arm. A significant asymptomatic LVEF decline, corresponding to what in the study protocol said that you should pause the HER2-directed treatment, was seen in 0.8% in the TDM1 arm and 5.3% in the trastuzumab arm. However, all patients received full resolution of cardiac symptoms and LVEF normalization after discontinuing their treatment. There has also been a very interesting publication recently from the large HERA trial, where they have investigated the patients receiving 1 or 2 years of trastuzumab within the trial. And here cardiac function has been closely monitored over a median follow-up of 11 years. And they divided the patients receiving trastuzumab into 3 groups. Group 1 receiving left-sided radiotherapy, Group 2 right-sided radiotherapy, and Group 3 without radiotherapy. About 1,200 patients in the groups with radiotherapy and 780 in the group without radiotherapy. The primary endpoints were over 10% decline in LVEF by echocardiography and to an absolute LVEF less than 50%, or the development of a cardiovascular event. And secondary endpoints, development of congestive heart failure or death due to a CVE. Looking at LVEF decline, this was seen in about 9%, a little over 9% in the group with left-sided radiotherapy, little under 9% with right-sided radiotherapy, and no radiotherapy. CVEs in 1.08% with left-sided radiotherapy, 0.9% with right-sided, and 0.6% with no radiotherapy. So here you see the corresponding graphs. No difference in the cumulative incidence of the LVEF decline. There was a higher incidence of CVEs seen with left-sided radiotherapy than with right-sided or no radiotherapy. However, the absolute numbers were still very low, and this difference did not reach statistical significance. So the conclusion here in this large trial with a long follow-up was that additional radiotherapy does not significantly increase the incidence of CVEs or LVEF decline compared to trastuzumab alone. And although there is some cardiac toxicity associated with the concurrent use, radiotherapy does not significantly increase the cardiac toxicity of trastuzumab. As I said, a follow-up of 11 years with cardiac function closely monitored, but of course these are patients that live long with the side effects of the treatment, so it will be very interesting to follow them even longer. But when it comes to trastuzumab and adjuvant breast cancer radiotherapy, we do have good data from large clinical randomized trials that the combination is safe. What about pertuzumab then? Well, we do have some retrospective studies, smaller in number. But again, the combination of pertuzumab, trastuzumab, and radiotherapy has in these been found to be well tolerated. In the Affinity trial, as we heard just recently, HER2 positive breast cancer patients were randomized to standard chemotherapy and 1 year of trastuzumab with pertuzumab or with placebo, with about 2,400 patients in each study arm. And radiotherapy was given concomitantly with the HER2-directed treatment. Adverse events has not been analyzed specifically in relation to radiotherapy. However, there have been no specific warnings or signs of increased cardiac toxicity in either of the treatment arms. When it comes to lapatinib, this was investigated in the adjuvant setting in the Alkner trial, including over 8,000 patients, randomized to either trastuzumab or lapatinib, or the combination of the two, with adjuvant radiotherapy given concomitantly with the HER2-directed treatment in about 70%. Again, adverse events not reported specifically in relation to radiotherapy. However, cardiac toxicity was low in all treatment arms. There was a higher incidence of skin toxicity with lapatinib. However, this is a common side effect with the drug also without radiotherapy, and its relation to if radiotherapy had been given or the timing and site has not been reported, so you can't really draw any conclusions from this. So the Delphi statements that we put together here was that trastuzumab, pertuzumab, and concomitant radiotherapy could be offered during adjuvant local regional radiotherapy for breast cancer. Here we had unanimous consensus from the expert panel. Lapatinib and concomitant radiotherapy during adjuvant local regional radiotherapy for breast cancer is safe. Again, consensus of 85%. However, when it comes to the newer TKIs, neratinib, tucatinib, and concomitant radiotherapy, we still don't have enough data. So this is something for all of us to investigate further in the clinical trials and prospective registration cohorts. So that was the adjuvant breast cancer radiotherapy. But what about intracranial treatment then? Again, quite a few pro and retrospective studies, naturally smaller in number. But again, all of them have found the combination of trastuzumab, pertuzumab, or lapatinib with whole brain radiotherapy or stereotactic radiosurgery to be safe. And interestingly, the study by Kim et al. And the study by Purcell et al., they found the combination of lapatinib and stereotactic radiosurgery to not only be safe, but that lapatinib actually increased the response of the radiotherapy without an increased risk of radionecrosis. And here you see a graph by the publication from Purcell et al., local failure with SRS alone, the upper curve, and with a combination of lapatinib. In 2017, Khan et al. Published a systematic review and meta-analysis of 6 studies, including over 800 HER2 positive breast cancer patients, of which 279 received lapatinib. And again, lapatinib in combination with SRS was associated with an increased local control, with no increased risk of radiation necrosis. But rather the rates of radionecrosis was lower or similar with the concomitant treatment. So Delphi statements here were that the trastuzumab, pertuzumab, and concomitant radiotherapy could be offered during whole brain and ablative intracranial stereotactic radiotherapy, strong consensus. And lapatinib and concomitant radiotherapy should be offered for whole brain and ablative intracranial stereotactic radiotherapy, again consensus. So back to the conclusion. We have found that the concomitant administration of trastuzumab, pertuzumab, and lapatinib is safe, both extracranially and intracranially. Thank you.